Muy buenos días. Mi nombre es Ernesto Gosser, soy médico, profesor de la Universidad Peruana Cayetano Heredia, y a nombre de la Escuela de Posgrado les doy la bienvenida a una nueva sesión de nuestro webinar que tenemos usualmente todos los viernes. Y con el apoyo de Anden Naturals, que nos viene acompañando desde que empezamos esta serie de webinars que tocan tópicos selectos del uso medicinal de cannabis. Hemos tenido varias temporadas desde el inicio de la pandemia, y este ha sido un espacio para discutir, presentar temas nuevos, profundizar en temas de interés y presentar investigaciones como se va a hacer hoy día. También quería anunciarles que ya estamos muy contentos porque el día miércoles hemos iniciado las clases del diplomado de uso medicinal de cannabis, el primero de su tipo en el Perú, primer diplomado, o sea, un programa de posgrado que tiene a participantes de varias partes del país y también algunos participantes de Ecuador y Bolivia. Muy bien, entonces hoy día tenemos otro tema muy interesante, muy importante, y que viene que toca un tema de mucho interés, pero también que es producto también de la investigación, y va a ser presentado por la doctora Estefanía Alfaro, quien va a ser la moderadora y a quien le doy el pase para que pueda iniciar este webinar. Doctora Alfaro.
Muchas gracias, doctor Gosser. Muy buenos días a todos y a todas. Gracias por acompañarnos. Sé que hay personas que vienen acompañándonos desde abril del año 20. Ya he perdido un poco la cuenta, pero viene a ser el webinar número 30, si no me equivoco. Y el día de hoy estamos muy felices porque vamos a tocar este tema que está demostrando a la actualidad muy buenos resultados con el uso de cannabis y cannabinoides. Y tengo una invitada especial desde Italia, la doctora Valeria Giorgi. La doctora es médica.
Hola, buenos días.
Buenos días, Valeria. Muchas
Hola.
gracias. Bueno, la doctora es médica e investigadora de la Unidad de Reumatología del Hospital Universitario Luigi Sacco, del ASST Fate Benefratelli en Milán, Italia. La doctora también es pianista, licenciada en el Conservatorio de Milán. En cuanto a su investigación, se centra especialmente en la fibromialgia, el cannabis y el dolor crónico. Ella es parte de la clínica ambulatoria de cannabis y fibromialgia en el Hospital Universitario Luigi Sacco y es administradora de datos y redactora de protocolos de ensayos de investigación clínica. Además, participa en la Asociación Italiana del Síndrome de Fibromialgia, AISF, una organización nacional sin fines de lucro que tiene como objetivo ayudar y apoyar a los pacientes con fibromialgia en toda Italia. También está cursando un máster en acupuntura y medicina china para mejorar el manejo del dolor crónico. Bienvenida, doctora. Estamos muy entusiasmados por escucharla. Recordarles a todos los participantes que están con el micrófono silenciado para tener un orden en la sala y que tienen los botones de chat y de preguntas para poder ir redactándolas las cuales van a ser resueltas al final del webinar. Doctora, bienvenida. Ya puede comenzar a compartir su pantalla.
Okay, thank you very much. Unfortunately, I don't speak fluently Spanish, but I will try to speak slowly English so that you can have your live translation. First of all, muchas gracias to Estefania, who made the invitation. I'm super honored to have this conversation with you. I think that this topic is super important nowadays. Cannabis is one of the most important therapies that can be used now, and it has to be shared, more education and more information to the patients and also to doctors who care the patients. So thank you, Estefania, and to all who are working on this beautiful project. I'm super happy to be here. So I'm going to be talking about cannabis and fibromyalgia. So basically, these are two important topics, but usually are a bit neglected and not really very much spoken about. So I think that first we can have a little bit of overview on fibromyalgia, because you know that all of you are much more expert in cannabis. So these are two little bit of neglected topics, because fibromyalgia is a form of chronic pain, and actually is one of the most common chronic widespread pain conditions. So basically these patients are feeling pain in all of their bodies, and this is the most important characteristic of fibromyalgia. But actually it is called a syndrome because it comprises a lot of different symptoms, and we will see them a little bit in detail today. So first of all, as we said, pain. So it is kind of head to toe. So patients feel pain in all of their bodies. And it is not a easy type of pain to recognize, but it is actually described in terms of neuropathic pain. This means that patients feel pins and needles, they feel electric shock, they feel burning, they feel a lot of different types of pain, and this is why it is difficult to recognize. But they also feel sleep disturbances, which are very, very common. So insomnia, and especially non-restoring sleep. So usually these patients, maybe they can do the polysomnography, which is the exam which objectively records how you sleep and which problems you have during sleep, and they have this kind of normal polysomnography, but they feel that they didn't sleep at all during the night. And all of this together then leads to a big fatigue. And it is both physical and mental. So these are two different types of fatigue. The physical one is the one that we feel when we have a big run or we walk a lot, and then we feel this physical fatigue. And this happens in fibromyalgia patients when they have a little bit of physical effort. With just a little physical effort, so for example, few stairs, they feel extremely fatigued. And this is also mental fatigue. So they feel exhausted after maybe reading 2 pages of a book. And this is extremely disabling. But actually, this syndrome comprises much more symptoms. So I wouldn't be going through each one of them because they are really a lot. But this is just to show you that fibromyalgia is not a single condition. It's not just saying, I feel pain, I feel chronic pain, but it comprises a whole lot of different conditions, and this means that we have probably different types of fibromyalgia, and this depends from patient to patient. So there will be one patient who will have just pain, cramping, and exhaustion, but then there are those who have significant cognitive dysfunction. So memory deficit, episodes of amnesia, which is not caused by any organic cause to the neurological part. Then there are some patients who have many autonomic disturbances. So for example, feeling dry eyes, dry mouth. Orthostatic hypotension is a common problem. So there is a decrease of the blood pressure while they're standing, and this is disabling as well. One of the most important symptoms of fibromyalgia are the regional pain syndromes. So some parts of their body which feel pain in that particular manner, meaning migraine for the head, irritable bowel syndrome, which is extremely common, pain during the menstrual cycle, pain during sexual intercourse, vulvodynia, and pain while peeing, which is dysuria, without having a frank cystitis, like a bacterial cystitis. So this is basically because the pathogenesis, so the cause of the disease, is still unknown. So we have these different types of fibromyalgia patients, which can be very different from one another, but we can use this umbrella term, fibromyalgia, for everything comprising that. So this is just a picture, but the most important thing is the relative importance of each symptom. First of all, it's pain. Then there is fatigue and sleep quality. So this just shows us the fact that we have to concentrate on these three symptoms to treat those patients. And then, of course, there are all of these. Depression and anxiety are very common, and it is very difficult to distinguish whether they are reactive or they are part of the disease itself. So I think that they are both. So from the one hand, depression is caused by the chronic pain, but this is true for any chronic disease. But on the other hand, the mechanism of fibromyalgia causes the depression. So it's this kind of a bidirectional causality in this case. But anyway, the problem here is that it is still difficult to make people and even physicians and politicians to recognize that fibromyalgia is a real disease. But actually, the history of this disease tells us that it has been a while that this type of symptomatology was recognized by the healthcare professional. And this is just to show you that even in the beginning of the 1900s, it was recognized, and it was at first called fibrositis because it was thought that there was inflammation in the muscle of these patients because they felt pain in their muscles all the time. They feel burning in their muscles. But then the histological study proved the inexistence of the inflammatory infiltrate. So the cause is somewhere else. Then the problem is to find objective elements of this condition, which is still a very controversial topic because actually there is no objective science that characterizes these patients. And this is the main problem, in which their suffering is not really recognized because there isn't anything that can be seen. Even lab exams are normal. The imaging exams are normal. At first, it was found that there was the existence of these trigger points, which were then called tender points, and then became part of the first diagnostic criteria. Fibromyalgia, as a term, was used in the 1970s, at first. But finally, in the 1990s, fibromyalgia entered the ICD, the International Classification of Diseases. How? With this first criteria, which, as I told you, comprise these standard points. These are 18 points, which was found that when digital palpation, so pressure of 4 kilos per centimeter square was applied, felt very tender. So the patient really jumped on their chair when they are touched in that point. 4 kilos per centimeter square doesn't really mean anything, but it's just to say that the nail of the finger has to become white while you press that point. So it's quite a bit of pressure. And of course, history of widespread pain. So these just 2 criteria. And then it was found that really wasn't very specific and sensitive for this type of patients. So is this problem important? Yes, because the prevalence, as you see here, is a lot in the general population. So here are some countries. I don't have data for Peru. I'm not aware of any data for Peru, but I will check. But in general, we can say that it goes from 2 to 6, even 8%. In Tunisia, there is 9%. In USA, 6%. But there are a lot of criteria used. The diagnosis is still a little bit controversial. But in general, we can say 2, 3, 4% of the general population. So it is quite common. And it is almost a female disease, meaning that about 90% of the patients, 80 to 90%, are females. What happens next? These are the 2011 criteria, which abolished the tender point examination. And this is quite difficult because a lot of physicians are still using the tender points to evaluate those patients, but actually it was found that they are not precise because the general population is in general very sensitive in those points. And they found more women because the women, I don't know why, but they are more sensitive in those spots. So for example, here at the knees, here at the flank, this is the great trochanter of the femur, and here in the back, this is the trapezius, the occiput, and so on. So they abolished that, and they found that there are some other criteria to be considered because there are a lot of other symptoms that weren't really included in the first criteria. So again, widespread pain index is fundamental. And then this symptom severity scale, which comprises the asthenia, so fatigue, unrefreshing sleep, cognitive symptoms, and also headache, pain in the lower abdomen, and depression. And these are the criteria with the points. Another important point is that the patient does not have a condition that can otherwise explain the pain, which was actually abolished afterwards because we have more criteria. Again, later on was found that they can concomitate. So for example, a lot of patients have hypothyroidism, which can be a problem, which can be a cause of widespread pain, but actually the 2 things concomitate. So this criteria here then was abolished afterwards. This is an example of the questionnaire that we can make the patient do. And this is the score. So they check where they have the pain and they check all these other symptoms. And if they score more than X, which is more than 12 points, it's fibromyalgia, but you have to consider the diagnosis. And these are the latest one, which are from 2018, in which they comprise more dimensions because the clinical examination has to consider more aspects because this condition is very complex and overdiagnosis is also not important to be done because it is a chronic disease and has to be treated in a particular way. And it's also a stigma for some patients because usually they are considered as imaginary as you say, like it's an imaginary illness. So it is difficult to say I am fibromyalgic. But anyway, 5 dimensions. Again, multi-site pain, defined as 6 or more in a total of 9, so easier to do. Sleep problems or fatigue for the least 3 months. But together with that, so if we consider just that, there is a high prevalence, so we have to consider also other common features: stiffness, hypervigilance, environmental sensitivity, which is fundamental, so intolerance to bright lights, loud noises, and so on, problems for recognition, other comorbidities, so as we said, irritable bowel and chronic pain conditions are important, mood disorders, as we saw before, depression, anxiety, but also, and we will see later on the importance of that, the post-traumatic stress disorder, sleep disorders, and inflammatory rheumatic diseases. And we will see later on that they are very much prevalent with chronic pain conditions, inflammatory conditions. So just to show, just an example, in rheumatoid arthritis, about 30% of the patients have fibromyalgia. And this is a differential, but it's much more a physician thing. I don't know, we cannot see that. So how is the pain in fibromyalgia? This is a very important question because it has to be found another term for pain, because it's a kind of new insight in pain. Fibromyalgia is a new concept of pain, which is common to many chronic pain conditions, because the normal pain that we can recognize in our everyday life is the peripheral nociceptive pain, so-called, in which there is a cause of the pain, which is usually a damage in a peripheral tissue. So I bump my my finger in a table, so I feel pain. And this is opioid responsive and NSAID responsive, so the normal anti-inflammatory. And then there is the neuropathic pain, which is caused by a damage in the nervous system, so to nerves, to central nervous system. And a classic example for that is the diabetic neuropathic pain. It is a difficult type of pain because it does not really efficiently respond to normal analgesics as the nociceptive one does. So the therapy is a little bit different. But then we have this other term of pain, which was newly found. So it is a newly type of pain, which is really recent, like a couple of years ago, which is nociplastic. And what is that? Is that it happens that there is a disturbed processing of pain. So there is no damage anywhere, so nothing completely irreversible, but still there is a disturbance in how the pain is processed. And there is no evidence of damage, like histologically seen, so it can be seen in a sample of the tissue, but still it causes pain. And it causes a very typical type of pain, which is usually called hyperalgesia or allodynia. The hyperalgesia is the response, like an excessive painful response to a stimulus which is painful for the normal population, while allodynia is the response of the patient which feels pain even though the stimulus is normally not painful. And this is a big characteristic of fibromyalgia patients. As we said before, if you touch them, they feel pain, and this is allodynia. And this is much more difficult to treat, much more difficult to diagnose. As we said, it is not responsive to the normal analgesics, but it can respond to neuroactive compounds, which alter the level of neurotransmission involved in pain transmission, because it is a disorder of pain modulation and transmission. And here are the examples, and headache, migraine is a really typical example. Irritable bowel syndrome is a typical example. So what is the problem with the nociplastic pain is that it is part of the so-called central sensitization process. So we have to say that central sensitization is a physiological process. So it is a mechanism of pain amplification that physiologically occurs after injuries in order to elicit a protective behavior. So I bump my knee in the table, I feel pain, I cannot even touch my knee anymore. So this is the sensitization, but then this process, therefore, when the healing process is completed, it regresses and the sensitization disappears so that I cannot feel pain in my knee anymore. It is like that in those patients, this central sensitization is activated but never regresses. And this causes some neurophysiological changes, so extension receptive field, electrophysiological discharge, and so on, but also clinically with hyperalgesia and allodynia. Okay, so this is our scheme that we did on Nature about fibromyalgia, and this is the putative etiopathogenesis of fibromyalgia, which sees, as we said before, there are many different types of fibromyalgia. So the etiopathogenic process is not univocal, but we have to recognize different pathways that can be activated, maybe more in one patient or more in the other. So in general, there is a top-down mechanism and a bottom-up. So the bottom-up one is more intuitive, which says that a painful stimulus in the body periphery stimulates the central sensitization. And if it is chronic, it stays chronic. So meaning if I have a chronic painful disease, so as we said before, rheumatoid arthritis, for example, I feel pain in my joints all the time, then the system can be kind of hyperactivated and everything is superactivated and it becomes fibromyalgic. This is true also for small fiber neuropathy, which is still a controversial topic in these patients. And then there is a top-down, meaning that for example, per se, the sleep alteration causes pain. So maybe there is a big insomnia, and this insomnia was found in many studies. Insomnia can cause pain, and it is really a rapid mechanism. So it was found that experimentally induced pain after about 10 days, sleep alterations, so basically insomnia, after 10 days causes pain. This is fundamental to understand. And then the depression, anxiety, but also maladaptive stress coping and low resilience are important top-down processes, which meaning that many of these patients, and in my clinical experience, practically 100% of them had traumas of any type. So they can be a peripheral trauma, so car crashes or big surgical procedures. So this is again, bottom up, but they also have traumas like violence in their families or sexual abuse and so on. And they, with the low resilience and low stress coping, they develop this kind of hypersensitization to all the stimuli. And then the genetic factors, of course, are very, very important. And this is the kind of correspective in terms of neurophysiology. So as you can see, the alteration in the receptors, the alteration in the neurotransmitter signaling, and so on. So the point here is the therapy. So the fact that these patients are so different one with the other, and they are so sensitive to external stimuli and also to drugs, therefore, makes it very difficult to treat. It is said that usually patients are not compliant with the therapy, but maybe because individual differences are not really taken into account. So it is difficult to interpret the randomized control trials because they do not divide the types of fibromyalgia, but they just give the same to anyone. But in general, we can say that there are 3 pillars for fibromyalgia treatment. One is education and fitness. So exercise is very important to treat chronic pain, also because it decreases the depression and anxiety, and they re-educate, in a sense, the muscles of this patient, which are seen that are imbalanced, they do not contract properly. So aerobic exercise, which has to be very, very gradual, because otherwise patient cannot really do exercise, and also patient education, which is really fundamental to make the patient understand their illness and understand how they can cope with that. Then there is the drug treatment and the psychotherapy, also because of the traumatic background of these patients. So what concerns us and me as a physician is the pharmacological treatment. And as you can see, here is the kind of rationale, which has to concentrate on the neurotransmitters that increase or decrease the pain modulation. So in general, the gabapentinoids are used to increase the hyperexcitability of the system. For example, the norepinephrine and serotonin system, which is part of the descending antinociceptive pathway, is decreased. So we use tricyclics, SNRIs, tramadol. So the SNRIs are very much used, the antidepressants. For example, duloxetine, milnacipran, which we do not use in Italy, but it is approved by the FDA, and also the duloxetine is approved by FDA for fibromyalgia. And also the pregabalin, but I don't think it really works. But anyways, so this is the, basically this is the rationale. The opioids are found that they do not work for this type of pain because the opioid concentration is increased, but the availability of the receptor, the opioid receptor, is decreased. So we try to give opioids to people that do not really have opioid receptor availability. So it was seen that they don't work and they have a lot of side effects, of course, being opioids. So cannabis, let's arrive to the hot topic, which is the use of cannabinoids, and in particular, cannabis as a promising therapy for FM. And it was found mainly in the recent years on the basis of patient surveys giving positive results. So the patient surveys highlighted that the cannabis can be really an important treatment for these patients. Why? Because mainly of a clinical hypothesis, because maybe it can be a kind of endocannabinoid deficiency state, as the other, as we said, concomitant chronic pain conditions as migraine and irritable bowel syndrome, because maybe it regulates hyperalgesia, cannabinoid deregulation. The levels of the endocannabinoids are very related to chronic stress. And as we saw before, stress and traumatic experiences are important in those patients. And they are also related to psychiatric symptoms, as cannabis is used also to treat anxiety and depression. And also lately, it has been found that can be used for post-traumatic stress disorder. But in general, they appear, so cannabis is appearing in the latest guidelines for this condition. This is one of the first ones that was the National Academies of Science, Engineering and Medicine, which in 2017 says that cannabis is useful for chronic pain and especially sleep for fibromyalgia. Very moderate evidence, of course. Here is the indication of the Italian Ministry of Health. So it says that cannabis can be used for multiple sclerosis and other pathologies with the spasticity and analgesia in chronic pain, when as a kind of third line, because they says when anti-inflammatories do not work, or cortisone or opioids doesn't work. So it is kind of the latest resort in this patient. This is the Ministry of Health in Italy. This is a meta-analysis that shows that it can be really important treatment in chronic non-cancer pain conditions. Here, a lot of conditions were examined: multiple sclerosis, visceral pain, 7 for fibromyalgia. But in general, we saw that it can provide a 30% reduction in pain. So I think that there are two problems here about the literature, the scientific literature, which is, first, there are no rigorous adequately powered double-blind randomized controlled trials, which are sufficiently long. We will see later on for fibromyalgia, there is really lack of data. But also an important thing that is usually a problem in meta-analysis is that cannabinoids are confused with cannabis. And I think this is a fundamental topic because because of the entourage effect, as you know. The problem is that we confuse synthetic cannabinoids, which is nabilon, for example, which is just few cannabinoids, and the whole cannabis flower, in which there is a synergy among the different cannabinoids and among cannabinoids and terpenes, which are seen that are very promising compounds, and therefore they change the therapeutic index of THC alone. This is coherent in fibromyalgia. As I said, there is a very small evidence because the trials are not done properly. And nabilon was tried, but it was found that it was not very good. Effects are higher than the really clinical benefit. So the route of administration for fibromyalgia can be different. So it can be oral, it can be done an infusion with the whole flower. But this was done once in Italy, like 6 years ago, because it wasn't found in any other preparation. So just this was found, but it is not precise. There is low extraction of the active principle, so this is kind of being abandoned. Capsules can be also used, low cost, and usual is the posology is stable, but what we use in my clinic is the extraction of cannabis in olive oil. It is given sublingual. It is easier to dose, precise. It can be dosed, and the dose can be changed really easily because maybe there is a period of the year in which the fibromyalgia patient stays better, which is usually during the summer. They can take less drops unless if they feel worse pain, they can increase the dose, but without dosing with the capsule, which is of course big dose. So if you take 2 capsules, it's like more than 100% of the dose. So I think it is not very useful, at least in this type of patients. And the extraction method can vary, so it changes the final concentration. So you have to really know a little bit of pharmacology in that from that point of view. So there are different types of pharmacological extraction. You can also vaporize. We use it less for our patients because, of course, the disease is chronic, so the pain is chronic and you have to treat it orally because the active principle is absorbed in more time and there is not the peak of absorption and the peak of effect. But vaporizing, I think that is useful for those patients who have really big insomnia problems, so they have difficulties in taking sleep. And the other problem is that they do not really want to buy the vaporizer because it's kind of costly, and also because this preparation here in Italy, or at least in Lombardy, my region, the region where Milan is completely reimbursed by the national health system, so you don't have to pay anything to the pharmacy, whilst this one has to be paid, but of course just once. So here are the studies. They're not much, but here is the very first one, which tried to think about cannabis in fibromyalgia patients, and it is just one inhalation of these 3 types of compounds. This is the pharmacokinetic of the different compounds, and after a single vapor inhalation, they found that there was a 30% decrease in spontaneous pain with this compound here, which has both THC and CBD. But the others, this is just THC and this is just CBD. As you see, the one with CBD alone is really less effective than placebo. So here we can see that maybe the entourage effect again is very important in this type of patients. So this is another study which investigated the cannabis as an adjunctive treatment. So this patient had their stable treatment, which was opioids, together with duloxetine. As we saw before, it's a standard for these patients. And for low back pain, it was added medical cannabis, which in this case, again, was vaporized. And it is a low THC dose. But still, the patient's global impression of change was higher, so very much improved with medical cannabis, while for the opioids that we saw before that are not really good for chronic pain, and in particular fibromyalgia, was very, very bad. And interestingly, so there is the amelioration of the VAS for the pain, the FIQR, which is the fibromyalgia impact questionnaire, which is the impact of fibromyalgia in the daily life. It's a questionnaire, but also in the Schober test, which is the lumbar spine flexion. So after 3 + 3 months of cannabis, there is improvement in all these parameters. And this is again the global impression of change, which after the third time point is ameliorated. This is our study, and we saw that actually we gave, as we saw, oral cannabis. We used 2 different types. So the Bedrocan, which is a lot of THC at night, and Bedial, which is both THC and CBD in the morning. And we used all these scales, which are all self-reported questionnaires. There is the ones that are just for fibromyalgia, which is the FAST and the FIQR. This is the anxiety and the depression scales. This is the sleep and the fatigue. And we saw more than 30% clinical improvement, which is usually considered relevant in the literature for the sleep and the FIQR, and a little bit of improvement in anxiety and depression scales. And this is the therapeutic groups, let's say. So about less than a half of the patient change their therapy because of cannabis. So usually this is an observational study, so we didn't really do a randomized control trial, but we saw that those patients who had to add cannabis in their pharmacological treatment, it was because their standard therapy couldn't work. So they actually, about half of them really reduced or even stopped their previous treatment because basically it wasn't very effective, but they were just treated with cannabis. So our conclusion was it was important for sleep disturbances in particular, and it correlated with BMI. So the higher the BMI, the less the effect. It is because of the pharmacokinetic of the drug, but also maybe for the higher inflammation that these patients have. So maybe they would need a higher formulation. And of course, this was a 6-month observational period at least. So it was a rather important observation. And this is a very, very recent one. This is from 2020. That was a double-blind placebo-controlled clinical trial, just 8 weeks, and just 17 women, but it's still an important trial in which they gave a THC cannabis oil, so again, oil on symptoms and quality of life, and they saw the benefit for the FIQ, as we saw before. This is the fibromyalgia impact questionnaire, and especially for pain and fatigue. Here they saw that actually the placebo group was significantly improving in depression score after the intervention. So in conclusion, that there is still, of course, lack of evidence because of this lack of randomized controlled trial, but still it has to be considered in this patient. It can be a very promising treatment, and most importantly, it is opioid sparing. So this patient present to their physician that they are desperately in pain. they have this excruciating pain all the time. So what the physician usually do is that they give opioids to them, oxycodone, as we saw before, or even fentanyl. And they really do not feel any better, but they have the side effects and they become dependent from the therapy. So cannabis is really, maybe really important for this patient. Even if we saw that probably, as all therapies for fibromyalgia, they maybe work just in 30% of our patients. And again, so the best therapeutic strategy has to be found, posology, the ratio, and treatment duration, and the subgroup of these patients that are most responsive. And this is all. Thank you very much. Maybe it was a bit long, I don't know.
No, it is fine, Dr. Valeria. Thank you
Okay.
very much.
Thank you.
I really like it because you have explained us all the history of fibromyalgia and the criteria they were using in the 90s about fibromyalgia that nowadays we don't use. So I wanted to ask you, and we talked about this before, the first strategy for the fibromyalgia treatment, do you think it would be a pharmacotherapy, or we can go with other therapies before?
So this is an important question because from the latest guidelines from the EULAR, which is the European Association of Rheumatologists, they actually say that the first therapy has to be just non-pharmacological. So education, fitness, maybe loss of weight, and treatment of concomitant condition and all of that, diet. But actually what we saw in the clinic is that those patients are usually are having been misdiagnosed for a lot of time. So they have been in pain for a lot of time, but they weren't diagnosed properly. So they went to the gastroenterologist and then to the endocrinologist and then to the whatever, otorino, and the neurologist for their headache. So they have been in pain for so much time that then when they get the diagnosis, you have to give them pharmacotherapy in the end.
Mm-hmm. Thank you. And in your experience, what is I know that you are treating patients with fibromyalgia because other rheumatologists do not have the experience. And what do you use? What cannabinoids do you use with your patients?
Yes, so we usually give this type of these two types of oil. So there is a cannabis extract in which there is one formulation which is mostly THC rich, and it is given during the night. And it is given in the night because it gives the most side effects, so maybe a little bit of dizziness and vertigos, but it is given in the night. So for some patients, it is super beneficial for sleep.
Mm-hmm.
And this is, as I showed in the slides, is 19 to 22% of THC. It's, of course, it's an extract, so it's not really that in 100 milliliters there is 20% of THC, so it's not really linear because it depends from the extraction method, but it's still a lot of THC. Mm-hmm. And during the day, or for those who do not tolerate that much THC, we would give the THC 6% and 8% CBD, again in oil, which is the bediol oil. I say bediol just to simplify because this is the Holland grown plant, but there is the Italian also formulation, which is called FM1 and FM2. The FM2 is kind of the same of bediol, so we can change the kind of brand, but in the end, that's the formulation. So we usually use THC because otherwise it doesn't really work a lot for pain.
Okay, so you use a ratio 1:1 THC CBD during the day and a THC rich extract at night. This medicine
Exactly.
is given by the university, is given by the state health system, or
So
patients have to pay
yeah,
for it?
yeah. So here in Italy, the legislation is so the THC can be given by the pharmacy because it is indicated, as I showed by the Ministry of Health. But the reimbursement depends from the region in which you are. So, for example, Milan is in the Lombardy region, so you go to the pharmacy with the prescription, and they just give it to you. Whilst in Piedmont, which is where Turin is, I don't know if you know, but it's really, really close to Milan, but it's another region that has a different legislation, so you have to pay for that. So the doctor gives you the prescription, you go to the pharmacy and you have to pay. And for example, the cannabis extract in the oil is about 200 euros per 50 ml.
And people are, they receive well cannabis, or they are really afraid, they have doubts, they don't continue to use cannabis, or they are, or they receive it good?
It depends, because mostly they come to our clinic because they want cannabis, because usually fibromyalgia patients are very informed about their illness and about the newest treatment that they can have, because usually they are in pain all the time, so they're actually surfing the internet finding the newest ones. So most of our patients come to us that they want that therapy, so usually they receive it well. But I saw that the older patients have much more difficulties in taking that kind of treatment, and I think that is completely cultural.
Okay. Doctora, going back to the mechanism of action of cannabis in fibromyalgia, like a clinical pearl, what would you say you think is the mechanism that cannabis acts in our body for fibromyalgia?
So it is, as we saw, an entourage effect, as you know. So I think that from one side, there is the action against pain. And as we saw, the THC is mostly active against pain because it activates the endocannabinoid receptor. So THC is a potent endocannabinoid receptor agonist. On the other hand, there is the action for sleep. And on the other hand, again, there is the action on the psychological and psychiatric disorders. So here is the difficulties in those patients, because there are some of them who have really post-traumatic stress disorders. They had really violence, they have been abused maybe by their spouse or whatever, and they cannot sleep because of the dreams they have, for example. I have few patients like that. So maybe, and I saw that is newest type of therapy, which is THC for post-traumatic stress disorder. So I think it is a kind of difficult. Also, CBD in those patients who have big inflammation in the bowel may be super important because of the anti-inflammatory effect. So maybe those patients who have a prominent abdominal symptomatology, or they have problems of chemical sensitivity because of the of food, of any type of sensitivity that they have for drugs, they're super sensitive for anything. Maybe the CBD can be more maybe better because of the anti-inflammatory effect and the effect on the inflammatory cells.
So we are treating a lot of targets, not only the pain, but also the emotional, right? Because we have the evidence that THC works really good with the amygdala and the prefrontal cortex to arrange the PTSD, síndrome de estrés postraumático,
Exactly.
and also CBD for the serotoninergic receptors for the anxiety. And that's all mixed up in fibromyalgia.
Exactly.
Do you think, Doctora Valeria, that cannabis can be a first-line treatment?
I think that in some patients, it has to be first line. So, for example, in those patients that have prominent fatigue and they are kind of depressed mostly, the antidepressants may be the first line. But then in those who have cramping pain and insomnia, which are basically a lot, it should be used at first line, because otherwise you go from anti-inflammatories, so the NSAIDs, ibuprofen, or whatever you can use, to opioids, but they, of course, they do not work because you focus only on pain. And maybe for those type of patients, cannabis may be the first line.
Okay, I think the same. It depends of the patient, right? It's individualized medicine. So I will be reading a few questions we have from the public. They are really thankful with your presentation. And
muchas gracias.
So they are asking about, is there any terpene recommendation you can give with the cannabis extracts that works with for inflammation and pain?
This is a good question. I have not been studying much terpenes, but I saw it depends on the, like what I know, it doesn't really focus on one terpene or the other. But I know that there are some types of extraction in the oil that that keep the terpenes more. So the problem is not giving one terpene or the other, but maybe getting an extraction method which guarantees the most of the terpenes to be maintained in the oil. Because of course there, you know that there are a lot of terpenes, like hundreds of terpenes in the cannabis. So yeah, I read, but basically almost all of them are beneficial, can be beneficial because of the anti-inflammatory effect and the calming effect, maybe limonene, but focusing on one. So yeah, maybe you can use the essential oils of lavender and whatever you can use. But I think that the most important concept here is that we are focusing on the whole flower, is that the extraction method should preserve the most of the terpenes, because maybe you use the cannabis oil, which you think that there are a lot of terpenes, but the extraction method used doesn't keep the terpenes in the oil. So I think that the principle is basically that.
Yes, because terpenes are really volatile. They get rid of them with extractions. Talking a little bit from experience, I think that, well, I told you that here in Peru we have the opportunity of making magistral formulas, to make a formula of cannabinoids and maybe adding some terpenes. I personally use linalool, that is calming, hypnotic for night, and limonene, that is also calming, but it activates the person. It gives more opportunity of concentration, to work better in the day. But also beta-caryophyllene, you know beta-caryophyllene? It is really anti-inflammatory. And I think that would be a good combination, maybe for the future. But full extract is what you said, is the best. Not isolate, but full extract. So we have another question, and they want to know if the time that the patient took from the start of the pain until the fibromyalgia diagnosis, maybe 6 months, 2 years, 10 years, it makes the treatment more difficult with cannabis?
Allora, sì. So usually the medium time they wait for diagnosis is 6 years. And it was seen that the more time to diagnosis, the less effective the treatment. So as we saw before, so if you can really start just with education and no pharmacological, so just doing Tai Chi, for example, which is super effective. There was actually a trial for Tai Chi in fibromyalgia. Tai Chi and diet and understanding maybe if you are intolerant to gluten, or maybe education to understand that you have that type of condition, which is chronic and relapsing remitting, which is also like fibromyalgia, and you are just diagnosed as soon as the symptoms present. So maybe you have a completely different response with respect to a person who was diagnosed after 10 years, maybe they are treated with cannabis and duloxetine and opioids and whatever you can use, maybe more cannabis, but they still are, maybe they have been so much time in pain that their pain system is so much sensitized that of course the response is always non-satisfactory.
Okay, so the...
Well, it also depends, I think, sorry, that how much the person wants to heal, you know.
Yes.
If you have been diagnosed for like 2 years ago, but you don't want to get better because people give attention to you, and there are some patients who are like that, you don't really want to get better, nothing's gonna work. I mean, you can really help just a little bit, but nothing's gonna work.
Yes, the recommendation will be go to the roots of your fibromyalgia, right? Look what you're eating, what you're thinking, or try to understand your trauma. And also cannabis and cannabinoids for pain, for anxiety. But if we don't go back to the roots, then we won't get rid of it, right?
Yeah.
We have so one of the participants didn't understand good about what you said with gabapentinoids. They are not good for fibromyalgia treatment.
Okay. So gabapentinoids, in particular pregabalin, have been very much studied for fibromyalgia. So this is because they made a lot of randomized controlled trials. I think because the pharmaceutical company is very powerful. So they made a lot of these trials, and they found that actually some patients had amelioration of their pain. So it was approved by the FDA, so the US National Regulatory System for fibromyalgia, together with duloxetine and milnacipran, as we saw the antidepressants. The European Agency for Medicines hasn't approved any of the pharmaceuticals for fibromyalgia, so there is everything we use is off-label. I think that the pregabalin is used mainly for those patients who have neuropathic pain, which is very important. The degree of neuropathic pain, maybe they have discopathies, or maybe they really have diabetes, maybe they have lesions in their small fibers. So they have a prominent small fiber neuropathy and a neuropathy symptomatology. This is true, but in my experience, clinically, so I'm young, I have not a lot of experience, but in my experience, it is not good for them. So I don't know, I prefer using other type of treatments. So for example, centrally acting myorelaxants to sleep, because pregabalin is basically given in the night for sleeping, but it is too much for these patients. So they are too much kind of sedated. So this is a personal opinion. So I don't think that they are really good, but from guidelines, they're used.
Thank you, Doctora Valeria. We have many people that is telling us their testimony about fibromyalgia. So we have one about one person, Ananda Verde, that says that it took too long for her to get to the diagnosis of fibromyalgia, and now she's using cannabis treatment in flowers and oils. So many years ago she started. Her question was about the first-line treatment, which you already answered, and she wanted to know a little bit more about the cannabis regulation in Italy for the inhaled form of cannabis.
For the nail forms, is the same as the oil one. It's really the same. So let's say it's legal to give it as a treatment, and it's reimbursed depending on the regions. This is the same. So what changes is the prescription. So you write flowers for inhalation, or you just write capsule, or you can write extract in oil, you can write resin, you can write everything you want. There is just a prescription. So it's basically the same. For inhalation, you prescribe the flowers, so there is less work for the pharmacist actually, so it costs less to the state, and you can use it with the vaporizer.
Yes. Do you think that the treatment with cannabis will be for life with people with for people with fibromyalgia?
So fibromyalgia is a chronic condition. So as any other chronic pain condition, it's like whether you can have to take cannabis for migraine all over life. Yes and no. So it depends on how you deal with the symptomatology, and you can even use it during some periods of the year in which you know that you're feeling worse, like during the winter time or during the change of seasons. So spring and autumn, they're awful for these patients. And you can think about like stopping it for the summer, or you can even stop it if you really feel better in general in your life, where you're doing a lot of fitness, psychotherapy, for example. You can even stop it and take it if you have, I don't know, difficult periods. You have to change your house and maybe you're stressed, and you can use it more. So I think that yes and no is the proper answer to that question.
Yes. It depends also if we find the root of the fibromyalgia. And as I read, you are studying Chinese medicine, and it's all about also going to the roots, right? And
Yeah.
Mhm.
Yeah, in
Does that-
fact, I don't think that fibromyalgia is a unique condition. So it's easier for us as, let's say, Western doctors to say fibromyalgia, but for Eastern medicine, so Chinese medicine, doesn't really mean anything. So there is this type of patient, that type of patient, that type of patient. I think this is more realistic from a clinical basis, like daily clinical basis. But for us in Western society, of course, there is the PTSD condition. Of course, the problem with central sensitization is that usually, even if you find a root, it is difficult to get rid of the pain because it is kind of become normal. It becomes normal in the nervous system processing of a stimulus. Let's say it changes the processing of stimuli in general. So not only the fact that you process your trauma, it makes your central nervous system processing stimuli properly, because they are really processing stimuli of any kind differently, even strong lights or strong odors, even strong tastes, strong noises. They're all processed like pain-like.
Mhm.
So it is this extremely difficult to eradicate, keeping the root imaging, to eradicate that change in the neural
nervous system.
processing.
Yes. And maybe nowadays the scientific evidence is not enough, but we are started talking about neuroplasticity, right? And the intervention of the microglia, not only neurons in our central nervous system. So maybe in a few years we will have a little bit of answers of how to treat the sensitization pain. I wanted to tell you a little bit
And
about.
also with the
Yes, I hear you.
yes, no, I was saying just for the for pain, it was found that now the transcranial magnetic stimulation is also maybe promising, as they saw with depression, for example. So there are some trials, but they're really, really, this is very something new. They tried to stimulate the M1 because it's very, superficial, the motor cortex, and to see what happens with this type of chronic pain. And maybe it can be beneficial as well because you act on the plasticity, neuroplasticity itself.
Yes, awesome. I wanted to tell you a little bit of what I found about fibromyalgia in South America, because you are in Europe. And the country that has the more scientific publications is Brazil, the Society of Rheumatologists of Brazil. Here in Peru, from 1999 was the first publication of fibromyalgia. It was a paper of a doctor who was talking about his practice. So he asked to 100% of his practice, and 30% of them said that they had pain in the certain areas that were asked before for fibromyalgia. But he said that maybe 2.9 to 4% of the patients had really fibromyalgia, and that 90% of these patients have insomnia. So it is a little bit like the research you teach us, and we don't have numbers about how many Peruvians have fibromyalgia. There was a study made in Chiclayo, that is a city in the north of Peru. It was made and it was published in the Cayetano, which is the university we're speaking now. It's the research publications, and they found something really interesting. They found that from 500 patients that were interviewed, 4% of them had fibromyalgia, and they were men. So now we're speaking about fibromyalgia, not only in women, but only in men, right? And they said something that I believe a lot, and they said that usually people with fibromyalgia, and we speak about this the other day, are these people with personality type A, right? This personality that they want everything perfect and everything in that time. So maybe that's something that we have.
But they mainly because mainly for the women, mainly because they were raised in families where there is a lot of doverism. I don't know if it's called like that. So a lot of duty, a lot of things that they had to do. So they had this mentality of imposing things to their kids, and this is very common in those patients who have fibromyalgia. So I noted that this is more common in women, whilst in men, it is less imposed by the family because it's cultural. But from the point of view of men, it is mostly endogenous in a sense, this kind of imposing things to oneself, to the person itself.
Yes. And well, there are only 10 publications about fibromyalgia in Peru. So I expect that we make more publications, maybe with cannabis use in the future.
Awesome.
I am trying to read if we have more questions. Is it possible to use cannabis as a monotherapy?
Yes, we have a lot of patients doing that. It
Yes.
depends also on the tolerance of the other drugs. Since cannabis has a lot of formulations, different modes of action, it is much more, I don't know, plastic, like it is more elastic how to use the cannabis. So you can use one formulation or the other. You can change a bit the as you said, you have the possibility to add terpenes. I don't know if we have that possibility here. Whilst if you give duloxetine, you give duloxetine, you know, it's just that. So if you have maybe a little bit of intolerance to duloxetine, you have to stop taking duloxetine. So I think that monotherapy, we have a lot of patients who do not really, they stopped their previous therapy because cannabis is beneficial to them, or because they just don't tolerate other things. And this is very true in fibromyalgia because they usually, as we said, have decreased threshold of tolerance for any type of external stimulus, and this is true also for pharmaceuticals.
Yes. So maybe I think that we have finished with all the questions. Thank you very much. I think I have made like 20 questions.
It's okay.
So the last question that they just sent us is, what percentage of THC would you recommend for patients with fibromyalgia, arthritis, and other related inflammatory conditions?
So the percentage, maybe it's confusing because, as we said, the extraction method really varies the percentage. So I can say that the recommended, let's say, dose of THC is starting from 2.5 milligrams a day, and you can go up to 15 milligrams, for example. So in those patients who have a medium high therapy, there are about 15% milligrams of THC, which are divided, as we saw before, in a THC rich dosage in the night, which can be maybe 10 milligrams, and a less enriched THC during the day. But this is just because of the side effect, because if you get 10 milligrams of THC in the night, in the morning, you get really, really dizzy. You get high a bit. But so I would reason more in the terms of milligrams rather than percentage, if it is okay, is helpful.
Yes, well, the percentage is good for the oil. How much does it have? But then for the dosing is the milligrams. I wanted to make a parenthesis because I read that some people were asking if we can use THC in Peru. And I think that we have a law in Peru that allows physicians to prescribe cannabis. Physicians have to know about cannabis, and we use a normal recipe that is the one that has my name and where I can write anything for CBD and THC less than 1%. And we use a special one that is the same that we use for the psychotropic medicines. And we have to write in that one if we are prescribing more than one of THC. But we are allowed to prescribe THC. Nowadays, we have a lot of CBD products, but we also have THC products. We have one that has 20 milligram per milliliter. So it's a lot, but I wanted to tell to the audience that people can use THC in Peru. Thank you very much, Doctora Valeria. I don't know if you want to say something to our audience.
Easy to conclude. No, I was just have to thank you all for the attention. Maybe it's a boring topic a little bit, but it was really a pleasure to talk with you in this regard, because I think it is a super important topic, which is usually don't it by politicians is really not considered many times. I think because of the voice of the patients have to be heard more, because there is no, as we said, the big pharmaceutical company behind this type of treatment, and therefore the physicians and the patient have to speak a little bit louder for that. So I think that this type of meeting that is on the web. So I had the opportunity to speak to you about the European, experience are fundamental for all those who work in the field, to educate and to, make information about that, about this topic, that I think that for chronic pain is really, really, really important. So thank you, Stefania, for having me. Muchas gracias. Muchas
Muchas
gracias a
gracias.
todos.
Muchas gracias a usted. Thank you very much.
Okay. I want to say also thank you on behalf of the university, and it has been a very interesting and very informative and very well presented discussion, and we thank you very much for your participation with us today. Goodbye. Ciao.
Thank you. Goodbye.
Chao, doctora. Muchas gracias a todos los participantes. Recuerden que van a tener esta grabación en el YouTube de la Escuela de Posgrado y hasta la próxima sesión. Buenas tardes, doctor.
Chao,
Bye,
chao.
doctora Georgie.
Goodbye.